on the PEC lessons learned. Steve Nazario, for the past 12 years, has served as the Associate Program Director at Advent Health's formerly Florida Hospitals Emergency Medicine Residency, located in sunny Orlando, Florida. Dr. Nazario is one of the founding members of the faculty and was recently promoted to be the Program Director. He trained at Jacobi Montefiore in the Bronx, where he stayed on as junior faculty for several years prior to moving to Orlando in 2003. His Twitter handle is @TBK61. Carmen Martínez. Dr. Martínez is originally from Puerto Rico and did her residency at the University of Puerto Rico, followed by a fellowship in Peds Emergency Medicine from the University of Florida University of Florida Health Science Center, Jacksonville. Following graduation, she joined the Advent Health Emergency Medicine Residency Program, also again, former Florida hospital, and has served as faculty since then. In 2019, she completed a master's in science and medical education. Her interests are pediatric emergency medicine, research, medical education, and curriculum innovation. Her Twitter handle is @NEMRAC77. And I believe as my voice goes out, I am glad to welcome Dr. Martínez and Dr. Nazario, and I'm looking forward to hearing what they have to say. Thank you.
Hi, everyone.
Thank you. Good afternoon to everyone.
Thank you, Marianne.
And thank you to everybody at CORE for giving us this opportunity to speak to you today on the subject of Program Evaluation Committee and what we've sort of have come to find along our path here. We do not have any financial disclosures. I think that's the next big thing that we have to sort of announce, and Carmen will sort of go over some of the objectives.
So the objectives today are going to first describe what the ACGME means by the Program Evaluation Committee, describe the structure that minimum requirements that they have established, some of the hallmarks that could make your committee to be successful, how to integrate all this into the annual program evaluation, and some challenges that we have seen along the way and we have identified in our experience in this last few years. So what does SCGME means? It's the program director must appoint a program evaluation committee that will conduct and document the annual program evaluation as part of the program's continuous improvement process. The idea is for the program not to become static, become innovative, and make sure that the residents are receiving the best education possible.
Right, so there's some descriptions given, basically talking about that you have to have at least a meeting a year, but most programs will probably have more than just that, and that meeting a year is probably what most people say is the annual program evaluation, which we'll get to later on, further on down. There's mention of you have planning, documentation, development, evaluating sort of all facets of the program, so everything that's not learner specific, right? So that's learner specific is going to be more the CCC. And even when we started, we were sort of like, how do we divide this?
What is the difference?
What is the difference? For a small program like us, it was easy. I chaired both committees, the CCC and the PEC, and it was easy to switch from one role to the next because I had the same audience. But I can imagine that for larger programs, that was going to be a challenge because you may not have the same exact faculty present or members present, and the fact that we have residents as part of this that make up the structure of the PEC as opposed to the CCC. So that's a big elemental change. At our shop, we did not have the program director. We had the associate program director was myself, and it makes a difference. I think that in terms of we sort of can have meetings. Sometimes the program director was present, sometimes they weren't, but it was always that the reporting structure was clear and delineated as we had in the common program requirements. So that's the same for everyone. How you apply it, though, is you're given a very broad interpretation, and that's how we sort of look at that.
Yeah, the most important thing is they just set the minimum. So at least you need to have 2 faculty members that are not part of the clinical competency committee, at least 1 resident. In our shop, we use our chief resident as part of the PEC, but it can be any of your residents, and make sure that the chair of the committee is not the program director. It can be any other faculty but the program director. Like Stephen mentioned, we have a small shop, so our chair will be, it used to be our assistant. It used to be him, our associate program director, who would be chairing this committee.
Right. And then the other part is for anyone who's either chairing or deciding to be on there, you have to make sure you can devote enough time to this, because you need to know the common requirements for the specific and the common program requirements. You need to be very facile in what the ACGME rules and regs are. And it's kind of dry reading, but you need to know that. And then you have to be up to date. Every cord session, we were always sort of going through and highlighting what the changes were from the subsequent years of when we would go to the cord meetings. And it takes time to sort of get expertise in this. So this commitment is one that's hopefully multi-year for those individuals that you pick out to be part of that faculty who are going to serve on that committee for larger programs. They should be people who you're going to carry over year 2, year 3, or longer, because there's a learning curve involved in this, and becoming facile with the language and what the actual roles and responsibilities are.
Yeah, so it is important to define these roles and these responsibilities. And assigning roles, I think, is one of the most important factors, because then you can create expectations and assign tasks and create accountability to be able to accomplish the plans that we have established for either that meeting during the committee, or to be able to collect the whole data and create that action plan and make sure that action plan is happening. And in general, this committee is responsible to plan, develop, evaluate all educational activities. They're also responsible for reviewing and revising competencies-based curriculum, the goals and objectives of every rotation, what's not being in non-compliance with ACGME standards, create the big report, the annual program evaluation, with an action plan to improve efficiencies and implement changes.
Right, and one of the good things that Carmen and I have spoken about is in looking at this and reading up on it, because there was actually literature that talks about how you formulate plans of action, plans for process improvement, not necessarily germane to PEC, mostly they were CCC, yes. But you can draw the corollaries. But there are things within our own program that we're like, oh, maybe we need to address this or that. So it's actually been very educative for us and for how we're going to take a look at some of this in the future.
And then you have to create a timeline. Our time it's money, and we had a lecture today that was really interesting, and we just learned that $3.18 that's per minute. So you can imagine how
the labor cost per person for somebody at a meeting, right? So if you think of, you have 6 individuals, TikTok.
And then TikTok, right? So right. You cannot have meetings that are too long because they become not effective. So different things in creating a timeline. First, you have to identify meeting times and the frequency of these meetings. The program of the ACGME suggests at least once a year. I think the best thing is to have meetings either twice a year or quarterly, and then you can set some objectives for all of these meetings. And then you have to set deadlines to be able to accomplish what you want to accomplish and make sure that everything is going on task.
Right, so we hit all these pitfalls and all these obstacles, let's say, with people not fulfilling their deadlines or not taking a job, saying, oh, I'll sign up for this, and then not sitting on it, not doing much with it, or not taking it as far as we would want them to. And part of the role of the chair is also to make sure that, one, that things are being done in a timely fashion, and if not, sort of giving them a tickler, reminding them, by email messaging or by just some old-fashioned FaceTime with the individual and just saying, hey, where are you with that? What do you need? What do you need from me? What can I help you with? And again, sometimes people who are younger on in their faculty presence may be a little intimidated to say, oh, I don't know where to start, or what do I do with all this information, or I'm stuck, and they may not want to ask. But we're willing to sort of take that on and say, okay, let me help you through that. I don't know the answer either, but we'll discover it together, similar to the way we work with our trainees. And with creating a timeline, you also don't want to stymie somebody's individual way of working, because we all work differently. I work differently from Carmen, who works differently from Dr. Molins, and we'll have, we work well together, but it's sort of, we have to complement each other on our strengths and our relative weaknesses, and we need to learn about each other in doing this. And the prep work, there's tons of prep work that go through this, and there's some programs that we looked at that seem to have really elaborative spreadsheets and have this detailed amount, and we'll get on that in a moment in terms of data that goes in this, but it's a mountain of evidence, and you have to know how to prepare for getting to that, which is our.
Yeah, and this also becomes important on depending on the size of your program. Because if you have a small program like we do, we see each other every week, we're sitting at the same table, but when you have large program with more faculty, then everyone's times might be conflicted. So making sure that you create those meeting times are important. And then it comes to the data gathering. So the amount of information that you have to get and to review, from evaluations of the program, how the residents are being evaluated by the faculty, how the faculty is being evaluated by the residents, and how other ancillary staff is evaluating the residents. How are the didactics going? The conference, do they like it? Should we change it? It is a lot of data that you have to create, and then how are you going to divide all this data between the members of the committee?
Right, and getting data from graduate surveys, it's like pulling teeth.
Those are hard.
Getting those, it's painful. It's a painful process, and we look at it and we go, well, they just left us a few years ago. Why don't they want us to answer us? Looking at, and there's nothing that's taboo. You have to look at your program, your affiliation agreements with your offsites, with if you haven't looked at your OB rotation in 5 years, well, there's a problem with that. You need to go back out and reach out to them. If there's an alteration in the ACGME requirements that we're not privy to, what was satisfactory back in 2016, well, 2018 changed that. Answering citations, answering complaints from administration, complaints from a particular work site, faculty complaints, resident complaints. You have to sort of be honest with yourself if you're looking at this whole process of improvement, incorporating all that data, and how do you give that? Now, does everything get equal weight? No, I'd say no, but you need to be sort of upfront and honest, and what can we tackle, and then distill what are the necessary elements that you're going to really focus on when you draft up your annual program evaluation, when you draft up the written report that you're going to send forward to your GME office or your or upload to web ads. Policy review. We were just talking about that today earlier. Periodically looking at your manual, looking at your policies. We were addressing social media policy. Someone at another residency within our system tripped up on something, and it's triggered a firestorm of controversy. And I'd rather not be my position working with our residents, because sometimes those things can get out of hand, and then even I can't save them. They're going to be out there. But making sure that the policy reflects what your current status is.
Yeah, we have to keep up with the times, right? Probably 10 years ago, social media wasn't that big of a problem, or but now it's becoming, it is part of our education, but it's also it can get residents in problems. And when you think about all of this material and everything that you have to accomplish, setting priorities, it is really important. So you have to identify what you want to work on first, and what is going to be your action plan, and how you're going to target this. So my recommendation is that so once you set up those meeting times, you need to set up objectives for that meeting. Right. So then you don't get lost in too many information, too many talks, too many kind of sidelines,
Yeah,
right?
Carmen's going to hate me because I'm going to quote one of our faculty members who would always say, "Stay focused on the task at hand," and we come to that, and we know exactly where that comes from. But it's true. It's what's central to your PEC review? What are the most urgent matters? And then when there's a question about it, rather than go down a rabbit hole or go down a distraction, go back to what are your written rules? What are the rules that you have sort of stipulated? And if that doesn't answer it, then go to what the ACGME has written out, because we pretty much have probably all copied and pasted those requirements onto our own procedures, because I know that's how our manual looks like. And it's a matter of, because of that, what is the priority? It's coming back with solutions, because at times it's not time to do, while it is a committee and you're meeting as a group, times you need to sort of step back, answer that question and come back, but answer that question so you're ready to prepare to answer that next month when we meet, or the very next time that we need an answer for that. And early on, we had lots of interruptions and side notes, and we would have meetings that would drag on for hours. And then at the end of it, you said, what got discussed? I mean, we had 10 agenda items, we covered 2. And that was part of the learning process, myself included, for being chair and sort of having to corral everybody and herd all the cats together and bring them in. But it's also recognizing and acknowledging everybody's contribution, because I didn't want to alienate any one person, because they all were vital to me, especially in a small program. In a larger program, I guess you can switch around one player for another, but with 6 faculty, we're
really hard to do that.
We're hard up on talent there, so we gotta work with each other.
Yes, and some examples for those meetings is, should we talk about today about the assessment of the program design? Should we just today, let's see, we had an action plan. This action plan is implemented. Is it going according to the plan or not? Are we maximizing every possible outcome? So those are some ideas that you can have for every of the meetings, and not try to tackle all of the topics at once in one meeting and every single meeting.
And I think it's fair to say that even if we deviated from what our action plan was, well, why did that happen? And can we answer that question that way? Or perhaps we thought we can solve this in a year. No, it's going to be a 2-year. No, it's going to be a 3-year process, and we will continue to work on it. But you have showing progress and showing that you're giving written evidence of that progress. What have you done in the intervening time period? Not like you just dropped it last January, now you're going to pick it up this January. No, we've been working on it, and this is the progress that we've made along. And taking baby steps sometimes is progress. It's moving slower than some people wanted it, but it's making the progress. And that's, again, with the continuity of having people on who are going to be there for a few years in the same kind of role, that's necessary for a program to be successful. At least that has worked, and it's worked out very well, because I think we have a pretty well-oiled machine coming in.
Yeah, and then at the end, the main thing for this committee is to come out with the big product of the annual program evaluation. If you think about it, it's like this big report card of the program, mainly divided into the resident performance, faculty development, graduate performance, and the program quality. So we need to make sure that the residents are learning what they're supposed to be learning clinically, they're doing their procedures, how are they doing based on the clinical competency committee. Our faculty is a representation of how our program is doing. So we need to make sure that our faculty is getting the appropriate development, how are the evaluations, how the residents feel about working with particular faculties, and which faculty members maybe we need to kind of come over. We need to give you some tips on how to do some bedside teaching maybe. And then just like Stephen mentioned, our graduate performance, right? We need to get that faculty graduate survey and see how are they doing, where are they at, are they just, I'm just working, I decided to go into faculty, which residents went into a fellowship after graduation. All of this is information that is important and goes into this annual program evaluation.
Yeah, and where do you start? And usually the best place to start is what was last year's program, what was last year's report, and usually we would start with that. We would have sort of some inspirational speaker, somebody to sort of liven up the group, like or liven up the topic. So occasionally it's an administrator, sometimes a more stellar faculty member that everybody has enjoyed. But we usually try to change formats every now and then, so not make it the same, oh, here we go, we're just having an excuse or a retreat. Some of the clinical faculty who are not as intimately involved with the program, but still participate and really do help teach the residents on the bulk of all the other times, have wanted to sort of come in and feel like, oh, it should just be sort of wellness and a wellness plus a day away from the hospital. But we know that that's only partly true. We need to have some things, that deliverables that we have to bring forward to the ACGME as sort of, wait, this has a script, sort of a script,
yes.
And we need to sort of bring that out. And then how do we continue with those challenges and sort of making sure that we have, again, the action plans, and if we met them, if we didn't meet them, what were the successes from last year? What were some of the high points? Because sometimes residents may have a short-term memory where they may not remember well why the schedule was changed 2 years ago. Well, like that was because you guys had a request that we make some alterations, and this is why. So the institutional memory is important to sort of have that and sort of go back and make sure that they sort of remember. The first years don't know.
Don't know.
The
yes.
seniors may have already graduated, and the second years may remember, but sometimes they need to be prodded into memory, and it's good. We've done sessions from small group sessions to discuss some of the hot topics. Sometimes we've done role playing, or we've had them come on and role playing. I remember one that was really well accepted was how are effective methods that attendings get feedback, and we had the residents do that while the attendings were
really
and we were looking at. That was interesting because it's like saying, oh, I know who that is. I was like, wait a minute, I think that's me, right? And it's meant in fun, but there was an educational piece that was up close and prominent as part of all of these, and we usually broke them down to have, so when we distilled it, they had fun, but at the end of the day, we went through and hit all the key notes, and then we have to write up this action plan after the fact, and it was the fishbone diagram for a few years, and then it became the SWOT analysis, and they changed the terminology or names, but there is some methodology to it.
Yeah, exactly. So the important thing is identify what are the problem areas, what is going to be our action plan, and how are we going to measure that the plan is working and it is improving.
Yeah, make mention about measuring, sort of like you touched on that, but could you elaborate a little bit more on that?
Well, I think that when you think about some of the challenges that come out of making the PEC and the program evaluation is, so you might want to catch the moon, but then how are you going to get there and how are you going to catch it? So it is really important to make sure that your intended outcomes are measurable. How are you going to measure those outcomes? And that everyone that is a stakeholder in this area is clear of, this is what I want to accomplish, this is how I'm going to measure it to make sure it was accomplished or not.
Right. And there's actually some learning, some theories on learning and teaching
yes.
that are out there that I was always taught, see one, do one, teach one, you're done. Good. You're good. You're a teacher. That no longer suffices anymore.
No,
and there
it does not.
There's multiple theories out there. And in terms of education, and it's useful for all of us to get educated on that as part of our own faculty development, even though some of us have been doing this for 20 years, and it still feels like there's a lot of material that I'm still learning, that I'm still having to sort of roll up my sleeves, and I was like, I have to do some homework, and I have to get back into there. And when you look at the challenges, like where are your gaps, right? We touched on it a little bit earlier about the action plan, but if you're not implementing your plan, or if it's not working out, but then why not? What are the obstacles? What are the potential problems? Is there resistance? Is there resistance within your institution? Is it within your department? Is it within certain individuals? Is it, who hasn't bought into this? And if not, is that a valid reason? Or how do you come to a consensus where you can have a win-win proposition across the board and acceptance? But you're right, it's how to measure, because then that's another, right? That means you have to take a step back. We can all talk about, oh, that's a great program. Well, what makes it great? What's stellar about it? why do people point to it and go, that's a great program? And then bringing it down to its nuts and bolts and saying
sorry I interrupt you, but
okay.
is it the amount of scholarity work that they're doing? Is it how many fellows are being produced, or how many are just going to work, or how many are going into academics? And and I think you kind of touched upon it, but one of the biggest challenges is how to sell that you want to change, right? We do have a big resistance to change, and the reality is the way we learn and how our residents learn are completely different within different generations. So trying to sell to a faculty that, well, I know this is how you usually do it, and this is how you learn to do it, but our residents are not learning the same way. So we have to make these changes. And then there's always resistance for that change. Always resistance.
There are some of my peers that were like, nope, this is the way I'm always going to do it. And sometimes I'm a late adopter on certain items, but I get prodded into, no, this is the better way of doing things. And whether it's simulation sessions, whether it's a lot more small groups, which again are labor intensive, mean that we need more faculty to be present and engaged that way. It's not just, oh, I lecture at 10, so I come in at 9:55 and I leave at 11:05, and that's it. You need a presence of your faculty and of more bodies to make these successful learning enterprises for our learners, and to also steep yourself into that. For the clinical attendings who are also teachers and focus on the bedside teaching, then also making sure this percolates down to them, that you can engage them, whether it's at sort of core meetings when you have everyone else around, or you have a night out, or you have one of these events like graduation or something like that, or an APE. Those are prime opportunities to sort of get some of these in more instructive modules out there for them.
Then and then all of this work at the end of the day is how to make our program keep being successful and make sure that it's their aims, the vision, and it's accomplishing the end product, which is our resident performance and how we educate and how they do the best patient care, right? So how does ACGME sees this at the end of the day?
Right. So in with the next accreditation system, and people are familiar with this slide, it's straight off of ACGME, and it's been dated for quite a bit, since 2013. But it talked about how we were moving from a very static process to one that's going to be more dynamic and ongoing reevaluation and critical analysis of what the program's like. In the past, if you were a program, you were successful, if you got a 5-year accreditation period, then you basically put that binder up on the shelf. You didn't look at it again until the next accreditation cycle. Then took the dust off of it, updated some papers, made a bigger binder, and put that in. Hopefully you mesmerize your examiner by how much paper you had in front of them. Well, that doesn't fly anymore. We need to move beyond that. And the slide you see in front of you had sort of within the text box, you'll see what is that. When you distill the 5 elements or 6 elements of the PEC or the annual program evaluation, those are the key ones. And then you look and you say, well, every year you have a cycle of, you have this annual program evaluation, you sort of feed into the next one, and you notice that you're ramping up towards that self-study. But it shouldn't be a surprise. It should be no big surprises by year 9 of your 10-year accreditation that you've been missing something, because you hopefully have been looking at the program in all of its elements all along and fixing the issues, or being knowledgeable that, hey, I haven't fixed this yet, but it's on my to-do list and I'm working on it. And that's where it's key. And that's where, while I remember hearing the next accreditation system and at court and sort of being taken aback, because it meant we were going to do a lot more work. We basically had a new program at that time. It was just a couple of years old, and we had to revamp what we had built and start anew, and nothing was sacred. We needed to take apart the program and take a look and address all deficiencies. And that's painful sometimes. But once it gets going, you know that it's less and less, and then there are new problems, and then you deal with them as you go. But once you have the right team going through this process, it becomes easier and easier as the years go
Yeah,
by.
and I think that's what is important about this committee is if the committee is able to keep on task and making sure that every action plan is implemented and the implementation is going like it's supposed to be, the 10 years of study should not be hard,
yeah,
because you're
hard.
been doing
Right.
slowly, you've been doing the work year by year. So just in summary, I hope that you guys kept up with us a little bit. It's but the main purpose of the committee is that we are evaluating the program, the mission, the aim, the strength, where to improve, where are the threats of the program, how the committee should, identify top priorities, keep in task, keep a deadline, making sure that it makes a plan and it comes out with measurable outcomes. Create that final product of an annual product evaluation, but at the end of the day, we're just trying to create meaningful change so our programs are growing, they're improving, and that our residents are receiving the best possible education that we can give them.
Yeah, and reaching out to other programs, reaching out to other people who would help you with being active within GME and seeking if they can offer assistance. And I would even say, even as part of the institutional reviews, I've learned from other programs, other residency programs, other specialties, from their annual program evaluations and peer review, how they got to this, how did they get to cover scholarly activities so much? Like, it wasn't EM, but it really helped me understand, oh, there's a process to it. Exactly. And learning that process and then bringing it back home.
Yeah, so now we're going to open to all of you who have, I don't know, listened to us ramble for a little bit. If anyone has any questions.
Hey, Steve, Carmen, great talk. Couple of questions. Any requirements for the chair, or do you just pick one strategically, somebody on the elder side and on the administrative side? And then we too have a small program, and sometimes our program evals contain a small N, and we get the tails, and sometimes only one very large negative tail from vocal minority. And how do you address some of the?
I'll take a stab at it. As somebody who wasn't a PD at the time, I felt like it was nice that my PD sort of picked me to do that. But I understood that you really have to be a people person. You have to be somebody who's a consensus builder, somebody who's not going to stifle innovation, somebody who's not going to always be no. Sometimes I had to say no, but I would be willing to listen to everyone's opinions and bring them in, and sometimes know when to cut somebody off or sort of redirect them, but do that in a palatable manner. I mean, because yes, you have an agenda, you have things. So finding that personality fit. If that person already exists in your group, that's great. If not, then that's a skill set that individual needs to build, or that you can say, I'm going to give this person a few years to build into that. I'm in that role right now where I'm now a PD, and I will have to switch over ownership to someone else, and trying to look at that and evaluating what are the personalities of individuals before me who can do that, who can do the discussion, lead a discussion, keep time agenda, who know and have a vested interest in the common program requirement, that will have ownership of that, because it really means you're entrusting quite a bit. And that's, I hope that answers your question.
And I think I would actually add, as a recently ex-program director, that I'm pretty sure you're not allowed to be PD and chair the PEC.
Correct.
Yeah, correct.
Right.
Correct.
And I gotta argue that, first of all, as the PD, you have so much on your plate already, but you
Right.
also feel such an ownership of the program that thinking about where the change should come might not be as easily perceived as it would be to someone who's not the actual PD. So I think that there's good reasons for that. And I think that having someone who can have a slightly less possessive view of the program, be able to try to come up with some of these novel ideas. I will also put forward that the CORD community is such a great resource, because so many of the program issues that come up in the PEC are certainly local and how you fix local programs. But as you're looking for innovation and novelty of how do you kind of change the big picture, I know that we found that the CORD community as a group were really coming up with novel ideas that we were then able to incorporate within what we were doing, which really helped us shake things up. I believe that there is another question. If you're a brand new program, how do you start a PEC? From Carolyn Mullins.
Well, I think one of the things that you can do as a new program is look at the other programs that your institution has. It will give you ideas, and it will give you a starting point in order to see what fits, because even though the minimal detail is not emergency medicine, we still have the common requirements, and it will help you and it will guide you into what you should do with your program.
And then again, as Marianne was mentioning, the CORD is an excellent resource. Looking at networking with other individuals, I don't know of one person when we were starting this program in 2007 who turned me away. They would offer me help, whether they were a very large established tertiary care center, looked radically different from what my program was going to look like. I got answers and I got help from people. People would show me parts of their PIF or share with me and be faster. And I think the same for developing a format like the PEC. And I'd say we had that frustration a bit when we were sort of starting that up, and we had to start from just the basement and build a structure from nothing. But you're right, approaching people at CORD and other membership, and I would be surprised if anybody would say no to that.
And at the end of the day, emergency medicine is still, it's still a small family. We're still a large, small group, and we keep close together. And now we've been in the position of giving feedback and giving orientation to colleagues of ours that have started new programs.
Right.
So we've been also being useful as a resource. So having that colleague that you went to residency with, that can be a resource too for you to be able to find how the mechanics of the residency are, and how you go about these different committees.
I don't see any more type questions, but what are some of the more substantial changes that you've seen come out of your PEC that helped shift, maybe whether it was the focus of the residency or was in response to something that was brought up that was a little outside of what you would have expected?
Well, I know we've come a long way with our rotations and how, for example, we have problems with rotations like OB, so we have to think outside of the box and look at other relationships.
We've eliminated some of the
Yes.
rotations just because they were just so bad.
Yes.
In our heads, it was
a great idea.
It was wonderful. This was a phenomenal idea. We had people who were passionate about teaching residents, and they did the exact opposite. They either scudded them out, or they were not doing teaching, or not. The goals and objectives, none of them were being met, and we had to scrap that and found something else. And then there were surprisingly other programs that we had to keep on and go and augment. Within our shop, pediatric intensive care went from 1 month to 2 months because it was one of those things that just, they were really receptive to us, really gave us great attention to our residents, had innovative ideas, getting them involved in pediatric procedural sedation, which was something that they rarely get in the ED. Here they can get tons of procedures. That was something that just came out, and we were like, well, hey, if you guys are getting that experience with the peds intensivist, let's make another month of it. And so that's something that came out of our PEC fact-finding missions.
Yeah.
Yeah, I know that we found OB to be a bit of a challenge as well. We had to shift some stuff based on that with our PEC as well. Well, I really want to thank everybody for joining us. I don't see any additional questions coming up. Is there anyone else out there with questions? This talk will be uploaded and available. So if you want to share it with your friends, you can go to Cord Connects on the Cord website. Tina usually gets it up by the next day. I don't know if the holidays will slow that down a little bit, but it'll be available so you can share with others, because this is obviously a topic that recurs in terms of its importance throughout the year. We will be doing another Cord Connects in January. And we look forward to hopefully having everyone join us. Thank you very, very much, Steve and Carmen. Thanks for sharing your knowledge and your information. And that was really helpful and a really nice, well put together talk that was able to be both concise and informative. Thank you so much.
Thank you.
Thank you.
Thank you, everyone.
Thank you, everyone.